all the participants for joining us today for the Denticare Live Endodontic Surgery Workshop. And the today's workshop is organized by the Department of Conservative Dentistry and Endodontics, Government Dental College and Hospital, Mumbai, in collaboration with the Alchem team. So today's topic is live telecast of post and core restoration case series. And the program schedule is the first surgery will be on the post relay of live relay of post and course case series of anterior tooth, and after the lunch we will have a post and core case series of posterior tooth. And for today's session, I welcome Dr. Sumit Bedia. Dr. Sumit Bedia is a professor in prosthodontics and postgraduate guide at Bharati Vidyapeeth, and he has 18 years of clinical and academic experience, and he has done a many pre-conference workshop and done the guest lectures, and also received the best paper award for his credit. And he is a peer reviewer board for many journals, and he has many publications at national as well as international journals. And he has a special expertise in fixed and removable prosthodontics, implants, and full mouth rehabilitation surgeries. I also welcome Dr. Abrar Sayed. He is a professor and head of Department of Conservative Dentistry and Endodontics at Government Dental College, Mumbai. With over 2 decades of experience in clinical teaching, he has been performing a live micro endodontics and other clinical procedures since 2004. And he has established himself as a pioneer in this field. And since 2013, he has also worked with various laser, both hard and soft tissues, and in-clinic CAD/CAM technologies in large varieties of cases. And he has conducted over 90 in-hand training programs, lectures, and workshops at various national as well as international platforms. And he also leads the teaching department of excellence, the Department of Microdentistry, and the Maharashtra University of Health Science, Nashik. Welcome, Dr. Abrar Sayed. I also welcome Dr. P.D. Joshi. He's a head of Department of Dentistry and consultant endodontics at Lilavati Hospital and Medical Research Center, Mumbai. And he's a eminent consultant endodontics practicing in Mumbai since 1980. His clinic is equipped with modern equipments in microendodontics, including the surgical operating microscope, and he runs his private practice focusing on the microendodontics and implant and restorative dentistry. And he is also in the panel of Bhabha Atomic Research Centers as a consultant endodontics. And he conducts various training programs on endodontics for practicing dental surgeons under the aegis of various dental associations all over the countries, abroad, and at his own center in Mumbai. So welcome, Dr. P.D. Joshi, sir. So today's live telecast will take us through the series of 2 series of clinical cases focusing on the post and the core restoration and essential procedure in the rehabilitation of endodontically treated teeth. So this case series is basically designed to provide a practical and evidence-based insights and showcase a real-time decisions making involving in these complex surgeries. So I welcome all of you. Now let's begin with our clinical journey all together. So now I hand over session to Dr. Abrar Sayed. Over to you, sir.
I'm Dr. Manoj Ramugade. On behalf of Department of Conservative Dentistry and Endodontics, I welcome you all learners for the 3rd edition of our live surgical procedures. Today, the CD program is on live telecast of post and core restoration, the case series. The aim of this program is to train the dental learners about the restoration of the severely broken down teeth by using various options in the post and core therapy. One option of the post and core treatment will be demonstrated in one day to form a series of the cases covering different alternatives in subsequent workshops. The learning objectives of the today's program are the clinical case presentation, online deliberation and discussion about the selection of the treatment options through the subject experts and questions posed by our learner, and live telecast of the clinical procedures. This is our today's schedule. I hand over the mic to Dr. Sandhya for the further program.
Hello, good morning. I am Dr. Sandhya. We are honored to have Dr. Anand Digambar Bidwe, an observer from Maharashtra State Dental Council. He is BDS and MDS in Department of Conservative Dentistry and Endodontics. He has clinical experience of 24 years, and he is currently working as a dental surgeon in Sir J.J. Group of Hospitals. Sir has completed his BDS from DY Patil Dental College and NDS from Government Dental College, Mumbai. And he is specialist in conservative dentistry and endodontics, and he brings wealth of knowledge and expertise to our discussion. Welcome, sir. Now I hand over mic to Dr. Abrar Sayed, sir. He is HOD in Department of Conservative Dentistry and Endodontics, Government Dental College and Hospitals, Mumbai.
A very warm welcome to all of you. Thank you very much. At the outset, I would like to thank everyone who has supported the whole event. This is the third session of our live surgeries from the operating room. We are going live on the YouTube, totally uncut, unedited. This is an academic platform for teaching and learning of clinical procedures as it comes. So in the initial 2 phases, we have done surgical interventions related to endodontic procedures. And I'm thankful to all those who have participated. We never anticipated that it will be so popular amongst people and there will be so many learners will be joining us. Your inputs, your suggestions, your criticism was really valued from our end. We are trying to improve ourselves and finding scientific evidences for all our decisions and actions. Thank you so much for your support. So far in the last 2 sessions, we have received registrations of more than 6,500 people. That's good quantum. That's an excellent support offered from every one of you. For today's program, more than 4,000 people have registered. So I welcome all of you. And at the initial go, I thank everyone who has supported us to organize this program. Today, we are going to carry out procedures regarding post and core. As we know that endodontically treated teeth are badly mutilated. They lose their support, they lose their strength. So people don't come to us for merely the obturations, but people come to us for pain and restoring teeth to have good function. And functions are the form of the tooth, shape of the tooth, aesthetics, more importantly, function of the tooth. So today we are going to demonstrate the age-old technique and the original technique, the benchmark technique against which all the newer techniques are always compared whenever they are introduced in the market. So today we are going to demonstrate you the cast post techniques. So in subsequent sessions to come, we will demonstrate newer techniques as well. We in our department are using cast posts on a regular basis. Cast posts are not only being used for anteriors, but as well as posteriors and premolars and molars. Even we regularly do cast posts in third molars also. So let's see how much time permits us today. We have ample number of cases lined up. And in subsequent sessions to come, we will again demonstrate use of fiber post, use of glass fiber posts, use of composite post, use of carbon post, anatomic post, and indirect techniques of post and core, and post fabrication using optical impressions through scanners, and CAD designing through various softwares, and milling of the post on the CAD cams. We do have in-house facility for Select2 to perform all these procedures. To begin with, the age-old technique and the technique which is the benchmark for post and core is cast post. So we begin our session for today with the cast post. I myself will be performing cast post procedures, making impression using inlay wax. And Dr. P.D. Joshi sir will be performing procedures using pattern resin. So to begin with, so welcome to the department. I'm Dr. Abrar Sayed. We have today a 31 years old male patient who have reported to us with complaint of decayed teeth. So this is the condition, preoperative anterior teeth. You can see all 3 to 3 are involved here. We are currently looking at restoring the smile from this 2 to this 3. This 3 will be restored using a composite. This 1, 2 will require a post-and-core. 1, 2, 1 will require post-and-core, and 2, 2 also will require a post-and-core. To begin with, we have done endodontic procedures in all these teeth. This is the pre-operative, sorry, this is the post-operative picture of 1, 1, 1, 2, 2, 1, 2, 2. Sorry, the nomenclature is odd here. This is central incisor, this is lateral incisor. We're done with, right? So you can see that the lateral compaction is reasonably acceptable. Extension of obturation is good. Slight amount of extrusion of the sealer, which is a welcome move here. So now we go on to the case directly. Thank you so much. I'm supposed to at least start, right?
Yeah, to all the participants, you can drop your question in the comment box during the live stream. Okay.
Seeing the whole case through surgical operating microscope. There are no other HD cameras or cams involved. As all of us know that microscope works at a higher magnification. So whenever I am not working on the tooth is likely to be thrown out of focus completely. So you may feel it's weird, but actually that is how a microscope works. So this is not a still camera installed somewhere in front of a patient. We are live through a microscope. So we will be changing the magnification as it comes. Okay. So various degrees of magnification will be used. We have a microscope that does not have stepwise magnification. We have a zoom in microscope today. Thank you so much.
Yeah, sir, one more thing. So audience can put down their question in the comment box. So yeah, we will address the questions also.
Earthquake आल्यासारखं का वाटतं चेहरा स्क्रीनवर? No, this color contrast has to change. The colors are distorted a little bit. Camera settings. Mr. Shankit can be called in. See, the lip are too reddish. Red is too much red here. ना सर क्या हुआ है? YouTube पे it's going correct because what I seen on our screen is color distortion here. It's going well there. Yeah, it's going well there. It's going well there. So this is an acceptable state. Okay. So, okay, back to the business. बंद ठेवलं दादा तुम्ही? हा. this is how the state of occlusion here is. I request Dr. Sumit sir to provide his valuable guidance about the planning of occlusion in this case. And why are we selecting a post and core and that to a cast post here? Over to sir.
Audible? Very good morning, everyone. Now, in this particular case, since endodontic treatment has already been done, so it is assumed that the restorability and the feasibility of restoring the tooth has been planned earlier on before initiating the endodontic. So, entire treatment planning ideally has to be done before you initiate the endodontic treatment. It's not that you first do the endodontic treatment and then plan for a post and then plan for the for the crown. So this entire treatment planning should be done before you start the case, before the now, since root canal treatment is already done in this particular case, we have to analyze the available prosthetic space, which is the restorative space in all three dimensions. Like what is the occlusal cervical space available? What is the mesodistal space available? Is there any proximal tooth migration, which is going to cause anesthetic result in the final treatment outcome? So you see the missing tooth area in all three dimensions, analyze that space first. Second thing is the occlusion, especially in anterior teeth, we have to see whether there is a deep bite or there is some less overjet or overbite. Sometimes there is excessive deep bite which can cause problem in crown restorations because the material of the crown then needs to be changed, whether we go for a monolithic zirconia or a PFM. So this treatment planning has to, now in particular case as this, if you see, okay. So if you see in 3 teeth, there is insufficient tooth structure, whereas in 2, there is some tooth structure left. So in that case, the coronal tooth structure seems to be sound, whereas in the other 3 cases, the coronal tooth structure is missing, and we need to restore it with some strong core. And for retaining that core, we will need the post. Now, over this core, we will be giving a prosthetic crown. So, do we have sufficient space for this crown? And not only in maximum intercuspation, we have to see whether this space exists even in protrusive and lateral movements. So, that is the incisal guidance. We will have to see whether there is space for this prosthetic crown in all the excursive movements, and there is no strong interferences by the lower anterior teeth, which can lead to failure of the prosthetic crown. So this occlusal analysis has to be done. Secondly, now this being anterior teeth, we are not expecting heavy occlusal load, but there will be oblique forces because it's an anterior tooth. There will be a lot of oblique forces. So we need to strengthen the core as well as by giving a strong post, we need to give a strong crown. So all 3 things have to be strong to resist these oblique forces which will be exerted on this tooth. So if it is a posterior tooth, if it would have been a posterior tooth, we would have thought in some other direction because more of vertical loading would have been there. Whereas in this case, we expect a lot of oblique loading. So the choice of materials, the choice of technique will depend upon the position of the tooth in question in the arch and the expected occlusal load on that particular tooth. I hand over to Dr. Abrar again.
Of the crown, we have shown you how the bite looks like here. It's a kind of heavy bite. Please close. If you see that the available space for the anteriors is very less. So caries often do not cause this much of destruction unless there are heavy forces which are deleterious to the overall situation. So what we realize usually loss of round structure and even post-endodontic failures, occlusion is a very, very important determinant of long-term success. So in this case, because of the deep bite here, this must have accelerated, the deep bite must have accelerated the breakdown of the anterior teeth after caries. Now, we are going to directly start tooth preparation. Some people may question here why to start tooth preparation first and then later proceed with the canal preparation. It makes sense because once you have margins in place in such cases, once you have margins in place in such cases, tighten this. Tighten that better. Yes. What is the degree of magnification we are working at? तेरे को अक्ल कम है क्या? वाव. तर डोक्यावर परिणाम झाले. Sumit sir, now I request him to talk about the preparation of the margin placement. थोड़ा खाली पा दादा. हाँ.
Now, when we are placing the margin, we have to see that two things. One is because it's an anterior tooth, the focus will be on aesthetics. It means we need to hide the junction of the tooth and the crown. So yes, definitely it has to be either equigingival or subgingival. At the same time, we also have to see, are we gaining some axial height by going subgingival? If we place our margin subgingival, we will get extra axial height and extra retention form of the particular tooth, which will also aid in retention and resistance. So coming to placing of the margins, we have to try to hide the junction of the crown below the margins. For that, in this case, we might give subgingival margin. Okay. And yeah, just wait.
As sir described, we are giving a supragingival, a subgingival margin in the facial area, and then we will give a supragingival margin in the palatal area. Naturally, as sir described, aesthetic as well as gaining some axial height. Because there is no ferrule left here, the cusp remains a very strong entity. Some of the margin still is carious here. So I'm working on that right now. This margin is still soft. I am not getting a healthy dentine. If you can see, there is caries on this point. Still, there are caries. It is a decalcified structure. There are still caries. I will have to excavate it. You see that there is a discoloration here. There is a discoloration. Can I get some hemostatic agent? Ferracrylate? Whatever. Which agent is this? During removal of the temporary restoration, there has been some gingival injury, very, very small, but that is magnified a lot under the microscope. So it's oozing. So I'm using some. मला हे दे ना ते आता होतं ना चांगलं आहे ते हा नाही निघत आहे ऐ जास्त आलं ऐ This is the hemostatic gel which I have placed to stop the bleeding in this area. Any kind of oozing will obstruct the vision, especially once you're working under the microscope. It will cause a lot of reflection and dazzling of the field. I'm waiting for the hemostat to have its effect, and see there are caries here still left in this area. So I'm going after the caries. I may remove it later. There are caries in the canal also here. So that also will be dealt with later. I think we have established the facial margin reasonably well. And now we will go towards the palatal aspect. This tooth is having a lesion still on the palatal aspect as well. The problem is you can't leave any kind of decalcified tooth structure because the caries will progress, one. Secondly, you will have a long-term problem of the caspo sitting on weak tooth structure. Suction move kara beta. हाँ करायचं दादा. थोडं तोंड उघडा. हाँ, जास्त नका. हाँ, बस.
Sir is placing a supragingival margin on the palatal side. Now we need to understand that the placement of margins will play a very important role in the overall success of the final restoration. Because if the final restoration doesn't rest on sound tooth structure, there is a high possibility of leakage and failure. Now, at the same time, you have to understand that during the excavation, if there is some unexpected tooth structure which is removed, which was not already considered before starting, we might have to change our treatment plan. Sometimes we have to switch from a bonded restoration to a cemented restoration, or from cemented restoration to bonded restoration, depending on the situation. So you have to be prepared for the unexpected results.
Now, after keeping the margin, unfortunately, during the preparation, we have realized that we are not left with any amount of tooth structure, supragingival. We barely have 0.5 millimeter structure above the gingiva here on the palatal aspect.
How beautifully sir has preserved as much as natural tooth structure, at the same time removing the caries. So both have to be seen.
So this is an unsupported structure, and still you can see that there is some yellowishness to it. So let us sacrifice it, no problem, because this will contribute to the long-term success of the case. We have left some caries in this spot and some caries in this spot that we will revisit after we are done with the canal preparation, because if I go on removing it, I might land up in an undercut, which I don't want at this stage.
This kind of situation will be, as we are going subgingival and deeper, we have to see the possibility of getting a sufficient ferrule. Now, what is ferrule? It is the band of natural tooth structure which surrounds the prepared tooth or the tooth in question, which will prevent the tooth from getting vertically split or preventing a vertical fracture. So this ferrule is the most important thing when we are doing a tooth preparation. And right now we are just seeing how to maximize this ferrule in this particular case.
I'll be using heat carrier to remove the gutta percha. Heat carrier, down pack.
For For removing this caries, to make sure, ideally, you can also use a caries detecting dye and find out whether the caries which is left behind is arrested or not. So if it is arrested, many times we can leave that decay, but that has to be detected by a caries detecting dye. These are not the margins for the prosthetic restoration. These are right now prepared for getting a perfect seating for the core. Later on, after the cast post is cemented or bonded, depending on the material, we will be preparing fresh margins for our prosthetic crown. It will be either a shoulder or a deep chamfer or a chamfer, depending on the material of the.
As sir has described, I am tentatively making, because I will not be immediately temporizing this case today. So as there is no temporization possible, I would like to keep all the margin at a stage where after cementation of the post and core, we can then decide about the final location and shape. If I do it right away, there will be need of immediate temporization, which is quite cumbersome. These are the margins prepared. Okay, and this is a very friable amount of tooth structure that needs to be eliminated. Unsupported structure. And remaining ferrule is extremely important for us. Very, very important structure for us.
That ferrule will be given by two components. Partial ferrule will be given by the core, and later on, the remaining ferrule effect will be given by the crown. The combined ferrule will actually prevent the tooth from getting fractured.
Akara? Okay, it's there. I'm using a heat carrier. Short bursts, not to cause overheating of the root surface. Are you doctor?
Since Darcy is preparing the post space, I would like to describe how deep you should go in preparing a post space. And I will also ask Dr. Sumit sir to answer a few questions which have come on the chat. So basically, there are 2 or 3 ways to look at the post space. One is how much is the crown height that you have on top of that tooth from the gingival margin. Suppose this is a central incisor, so approximately it's about 10 to 12 millimeter height. So you need to go at least that much height depth into the canal. So at about 10 to 12 millimeters. That is one way to look at it. Second would be to whatever is the height of the bone, the alveolar crest from the root surface, 2/3 of that height. So the post should be supported by the alveolar bone surrounding that tooth. So 2/3 of that height of that alveolar crest. And third would be at least leaving 3 to 5 millimeter of the apical gadapacha intact in the canal, because you need to preserve the apical gadapacha for the apical seal. So these are the 3 ways to look at the depth of the post. And accordingly, we remove the gadapacha. We can, if we want, verify the length on the radiograph, or if we know beforehand what is the working length of the tooth, then accordingly we can pre-assign the length on the post and directly can go into the canal. So these are the ways to define the post depth. The second is the diameter, how much diameter we need to prescribe for that post. Because you can't have too thin, which will break down very easily in transverse loads, and you can't have too thick, which will compromise the thickness of the dentine around that post. So both ways you will have to be careful about the diameter. So on an average, we look at one third to 1/4 the width of the root on the radiograph, which should not be more than that. Or minimum should be 1 millimeter of the post diameter in cross section. That is how we look at. Now, before we consider all that, we need to look at what is the mesodistal width of the root. Now, since we have a facility for CBCT, we can even check that. And lastly, we also need to look at the curvature. Now, since this is a central incisor, it would be more or less straight. But sometimes the root would be curved in the mid-root level. So in that case, you cannot go beyond the half of the length of the tooth or root, and you'll have to stop yourself at the curvature. So the root length would be, the post length would be reduced. And also, since this is a tapered post, because you cannot cast a very parallel post in this case, so you need to maybe have some anti-rotation around the post channel or on the surface of the tooth, so that the post does not rotate or the core does not rotate during the occlusal loads, because there will be more or less transverse load or oblique load coming on the tooth from the opposite incisors, as against, in the molars where there is a vertical load, where the post is compressed down into the tooth, but here the post is actually displaced labially. I'll just look at the question. Rajendra, can you open this?
What I'm showing on the microscope is, I will like to draw attention of everyone on the canal. I prepared the canal sufficiently to receive it. However, if you can see, there are continuous caries till the middle 1/3 or apical 1/3 of the canal. So in such case, it is impossible for a fiber post to achieve any kind of bonding. Or no post can be used because there will be continuous influx of the fluids inside to reactivate these caries. So I am treating the canal using scraping action of the piezos to eliminate this decay which is gone inside the canal. This is most of the times cause for your demise of a post. This is a microscope, so it shows it that loud. Otherwise, it's impossible for the clinicians to see it, okay?
Okay, I will be answering one question that has come. Which is the best way for canal preparation in obturation?
Wow.
The canal preparation is done with first by removing GP and then with the piezo reamers as per the depth that we select. Obturation technique, the best technique would be down pat in this case. And according to research, if you prepare the post room at the time of the obturation, that means you do only the down pack and not do the backfill. That will prevent the leakage into the canal while you are preparing the post room.
See, what I'm doing here is widening the canal a little bit. It may seem that I'm preparing the canal overzealously, but believe me, I'm protecting the canal in the long term by removing the carious walls. I hope the color difference is clear in the video, because I can see it in the microscope very well that inside of a canal is carious.
Also, you can see on the screen, the canal is not circular. It is a little bit oval. So this is the preferred indication of the cast post whenever you have an oval canal or irregularly shaped canal, and that is what you see in central incisors, generally a triangular canal with a little bit more width towards the labial surface as compared to the palatal surface. So that is an indication where you select a post that itself acts as an anti-rotation. Even a canine would have an oval canal. Again, a circular post in an oval canal does not fit that well because there would be some space around the post. So these are good indications for the cast posts. The shape of the canal, cross-sectional shape.
So lubrication. No.
Is there a chance of recurrence after endodontic surgery?
Take it. Everything is arranged here after the preparation of the other canal.
Here, in this case, once the post is placed, and if you have to undergo endodontic surgery, you can do it, and you will have to remove the apical gadapacha and place NTA in place of that, and that is possible. I would ask Dr. Sumit sir to answer on this question. Fracture of post and core, are they likely to occur, and what are the care and precautions to be taken while doing so?
Yeah. So in order to prevent fracture of the post, first will be the case selection. That is, during case history, we have to
mirror.
The patient is having any parafunctional habits. Is the patient a bruxer, first of all? You detect the loading which is going to be expected on that particular tooth. Second, you have to see the crown to root ratio. As we see for any prosthetic restoration, the crown to root ratio is of utmost importance. Now, in this case, the occlusocervical space which is available for the prosthetic crown seems to be average. It is not less, it is not too high. So we are not expecting extreme oblique forces in this particular case. So we will be following the ideal protocols like the post length and the diameter as per this particular case. Secondly, if the coronal space is excessive, if we have extra vertical coronal space, then we need to see to it that our post depth is maximum within acceptable limits, that is within 3 to 4 mm from the apical foramen. So we will use maximum depth of the post in such cases where the coronal space is excessive. Otherwise, if the coronal space is excessive and the post length is insufficient, again, there are high chances of breakage of the tooth, because whenever there are oblique forces levied on the anterior tooth, the labial portion of the cervical portion of the root is going to be loaded in very high intensity, which can lead to a fracture at the C junction. So you need to take care that what is the anticipated load. Secondly, if there is a deep bite during protrusive excursions, there will be excessive oblique forces on that particular tooth, which can again cause pressure load on the tooth beyond the limit, leading to post fracture or the tooth fracture. We have seen both kind of fractures, like post also fracturing and also the tooth which is fractured along with the post. So loading on that particular tooth needs to be seen. Next will be choosing the right material for the post and core. We always cannot be like, we cannot have a particular choice of post always. Depending on the case, we need to alter. Now, in this case, we are opted for a custom cast post and core, which will be strong because it is made of a casted material. It will have sufficient strength to withstand the occlusion load which is anticipated in this case. Yeah, so we have another question. Like in this case, where there is very less ferrule, should a crown lengthening procedure be performed prior to post and core? Yeah, it's a very nice question. I appreciate the person who has asked this question, because I think it's by Dr. Shruti Jain. Yeah, it's a very valid question. Now, as I told you earlier, that as we go deep subgingivally, okay, we are gaining two things. One is complete removal of carious tooth structure. Secondly, we are also gaining axial height of the tooth, that is in occluso-cervical direction, which will actually indirectly help us to get more ferrule. Now, sometimes if the caries is extending too much beyond, then we cannot keep our margins that deep, because that would lead to violating the biological width. So in order to prevent that violation, sometimes we have to go for a crown lengthening procedure. Now, in this particular case, it's not so deep that it will violate the biological width as seen on the X-ray as well as clinical examination. So we need not go for a crown lengthening procedure. But yes, if it is more deep, then in such situations, we need to go for a surgical crown lengthening procedure with or without ostectomy, depending on the particular case. In this case, we don't require crown lengthening procedure because we will be able to manage it without a CLP procedure. Now, in case if you don't want to go for a CLP procedure, there is another option. We can also plan for orthodontic surgical or orthodontic extrusions or surgical extrusion of the tooth, so that we gain a proper ferrule. Okay, there is another question in which it mentions, can you describe what practically is a ferrule? Basically, ferrule is a band, circumferential band of sound and natural dentine, which envelops the post-space preparation area, which will prevent the tooth from vertically splitting under occlusal load. So this will prevent the tooth from vertical split. Okay. So if you have seen in furniture industry or other mechanical engineering industry, you'll see that the edges of a particular item is having a cover of metal, like how you have the walking stick. So at the end, they have a cover which prevents the vertical split of that particular item. So same way, in tooth, we give a ferrule. On this ferrule, our core material will be bonded or cemented, over which a crown material will be cemented or bounded, which together will give a ferrule and prevent vertical split of that particular tooth under loading.
ठीक है, came back. Okay. ठीक है.
by Dr. Ramdas Palekar, that how much tooth structure is necessary for post and core. Now, if you see the literature, it is mentioned that for anterior teeth, it is recommended that for most of the cases, post is recommended because of the oblique loading which is anticipated in the anterior zone. But we also have to pay consideration to conservation of tooth structure because preparing a post space might also lead to weakening of the tooth. So keeping this balance in mind, we have this approach. Second point is, as far as remaining coronal tooth structure is concerned, we need to see do we have sufficient retention and resistance form of our abutment for the planned crown. If that doesn't exist, then we have to create it. And how do we create it? By doing a core buildup. But if that core buildup is having less retention or going to have less retention, we need to give a core. So again, back to the basics. If you see the definition of post and core, the post is required to retain a core. And if the core is not going to have sufficient retention, we need to do a post. Otherwise, only a core buildup would be sufficient. As we do in our routine cases, we do only a core. We don't do post in all cases. We do a post only in those cases where we feel the core will have improper or inadequate retention.
If you see the preparation here, all of you are seeing an elliptical extension in the mesial aspect of the central incisor. That is our anti-rotational feature. Okay, that's the anti-rotational feature. Can I have a long round burr with a long taper burr with a round end and apply suction there? Use suction. I'll use this beta. Use suction there. We have a EX22. To refine the anti-rotational feature and remove a little bit of an undercut here, I'm using a long taper burr with a round end because the edges have an undercut. Oh. This is a run out. It's a bent burr. Give me a new burr. Discard this burr. Give me a new burr. Discard this burr. F4, EX24, whatever, EX22. Give me any burr. No, sir, chalega. Any tapered, but it should be thick, not to cause sharp cuts vertically. There is a slight margin undercut, and I want to refine the anti-rotational feature given in the mesial wall. The 2-1 is prepared to a good diameter, so we won't have a problem of rotation there. This canal has not been extensively prepared, so you would prefer to give something here like this. See, it's refined now. I request PD sir and Sumit sir to have a look at the screen and tell me if any modifications are required to be done here with the preparation. I think there is an edge on the palatal aspect which is an undercut. We have an undercut here, this undercut. That's okay, I guess now. Okay, sir. Both are okay. Applying the media for separation. अरे एवढं थिक कसं काय केलं रे? Retractor. हा करायचं दादा. तोंड बंद करायचं थोडंसं. बंद करा, थोडंसं बंद करा. हा असंच ठेवा. This overhang is a little bit of an undercut that will prevent our draw. So single position of the mirror should show you the internal canal, all walls in equidistance, and the obturation and none other of the obstructing overhangs. So I'm removing it now. आ करेंगे sir थोड़ा हाँ बस. Flattening the surface. Sharp edges can be kept in bonded restoration and not at all to be maintained in any of the. I'm removing all the sharpnesses from everywhere. Unfortunately, I still see the caries in the microscope. So I'm compelled to remove them. You can't leave them inside.
One question by Dr. Fatima Sayyed, that is it always necessary to provide intentional grooves in anterior cast post restorations? Now, whenever possible, without compromising on the sound tooth structure, if you can provide an anti-rotation feature, it is always preferable. But in this case, as sir told, the canal shape is already oval, not circular, and we are going to make a custom cast post and go. The custom post cross section will be oval. That means it will have anti-rotation feature inbuilt anyways. But yes, as an additional anti-rotation feature, we can also incorporate a keyway or a slot that will lead to double protection from rotation. So it is always better if it is possible.
Yeah, because it is, say, anything, any concept those are described in a theory do not apply to all clinical situation. Everything that you read in the literature, in the research, or listen from a speaker is always applied to a specific condition. Everything is ultimately left to the clinician's best judgment of application. So what we need to do in all cases is, once you feel the canal is too circular and it may cause rotation of the post, if there is slight micro movement of the post which happens inside the canal and you feel that it is likely to cause micro movement and rotation, the demise of the post is very much possible and easy. So one has to be careful that that's not happening. So if you feel that the post is likely to rotate, then only you do it, otherwise you don't do it. I'm testing whether my base for my impression material is reaching to the depth or not. Yes, I am reaching the depth. So I'll start with making of the pattern. Angle is good for the viewers. Okay, then give me the spirit lamp. Give me a cotton roll, please. Yeah. This is saline. This is saline. दादा दादा कापूस ठेवतोय, दुखणार नाही तुम्हाला. कापूस ठेवलं नुसतं काही नाही. हा this is good. This will go unhindered also, mostly. Blade. Need a position to show. Do not tighten anything. Loosen up. Power supply of the chair. You cut off the chair supply. The touchpad is not working. Chair movements are not working. Shut down the chair supply. Power supply of the chair. Controls are not working. Yeah, put it on now again. We are good to go. Or else direct vision is better, not the indirect vision. We can demonstrate the fabrication of the post with an indirect vision. Akara dada. दुखतंय, हे दुखतंय. तुम्हाला जायचंय? जाऊ बाथरूम जायचं मला. जाऊन आरामात जाऊन. A patient needs a break just for 2 minutes. We'll take a break and he wants to use the restroom. A patient has taken a break. Meanwhile, to elaborate more on the questions which have been asked by the participants, the voice is echoing from outside. So slightly, they ask them to reduce the volume a little bit.
What if this care is extending to the apex?
Yes.
What will it be? Driving deeper.
See, in the left central incisor, in 2-1, we have found that there are caries in the canal. First of all, because of the magnification we have, our magnification is almost up to 40x. So we have a huge magnification that helped us to visualize that there are definite decayed carious lesion inside the canal till that level of the obturation, which we removed using rotary instrument scraping action. So that again brings in a question: when we totally rely on bonding, what will happen in such cases? At least Caspos is giving us a leeway to bypass this bonding procedure and giving us something which is mechanically sound and will retain for a while. One. Secondly, canal caries are a rare entity. Unless the carious lesion is really chronic, they don't migrate down that easily. And secondly, if the carious lesion has been very extensive and very chronic, then only canal penetration, lateral penetration of the microbial colonization into the canal wall will be this deep. So we suppose that the tooth has become non-vital more than approximately, Sumit sir, you would agree that around 8 to 9 years, this much of destruction will take place. So whenever, as I said initially, that once a newer technique is introduced into the theory or in the market, or any equipment or instrument is available, people immediately think that the old techniques have become obsolete. No. Anything new, any cutting edge technology that comes, it adds value to the what is available. Sometimes definitely it completely eliminates and refutes old concepts, fundamentally eliminates. But however, post and core is an area which is left to lot of factor. Every single decision that we make during the post and core is multifactorial. It can lead to opening up channels for success. It can definitely step you into a disastrous failure also. However, if you consider overall success of the post and core treatment, which has been asked by some participant, if I go strictly by the clinical trials and the laboratory results, post and core has been shown to have 9% failure rate on an average over the period of 6 years. So what are we looking at? If all the parameters are considered, if all the corners are checked, before you initiate a therapy, if you do 100 cases over the period of 6 years, you're looking at 9 failures. So almost you're seeking a success rate of 90 to 91%. So that indicates over the period of 6 years, if 90 to 91% of your cases are succeeding, that's quite fruitful. If not, what was happening? If not, we were removing those undermined teeth and replacing them by implant, or we are sacrificing at least adjacent tooth structures, two teeth, by doing preparation for a fixed prosthesis, or the patient was to wear a removal prosthesis. That's again more cumbersome for the patient. So if a post and core is executed nicely, it can exhibit success in the long term more than 90%, eliminating any other expensive and prolonged treatments. No treatment can be devoid of failure. In a mouth where natural teeth could not survive, we should not have a misunderstanding that whatever is being replaced by us is permanent. So definitely all the treatment that we execute will have a level of success and anticipation of a failure. So whenever we execute a treatment, always learn to prognosticate the timeline which can give you success and timeline that you can give success and failure, so that you can have appropriate dialogue and take the patient into confidence. I hope I answered the question about the success and anticipation of the failure rate. A patient is back, so we will be back to preparation of the pattern now. New gloves, please. Sorry, beta. What is it, sir? Okay. Okay. Yeah. You want me to answer that question? Okay. Tighten it. कर दिया? It will not move now anymore. मेरा स्पेट्स कहाँ है रे? This is good to go. And the one that we selected is good. दादा तोंड उगड़ा थोड़ा सा, हाँ बस. इतना मूवमेंट क्यों है रे माइक्रोस्कोप को? टाइट करना उसको. शंकित है क्या इधर? टाइट हो नहीं रहा है. ये देखना मूवमेंट ही हो रही है, टाइट क्यों नहीं हो रहा है? शंकित है इधर? हाँ? See, this is not working. Yes, yes, it has worked now. थोड़ा खाली बघा. बस. I'm applied the separating media. Yeah. Any questions you can? Rubber dam you want me to apply for? Answer for na sir? Yeah. The rubber dam is not applied here. Reason being that it's an anterior area where we could control the isolation reasonably well, as you all have observed. The only time where it has got a little bit of contamination where patient wanted a break, right? So even patient, I could not give a break to the patient with the rubber dam. So no added advantage as such. And this is moreover an academic program where MDS students appear for the exam. And traditionally, for the past almost 30 years, we have not been applying rubber dam for this procedure, even in MDS exams. So if you prefer to apply, do apply. And I think we should not have that feeling of applying the rubber dam for the sake of applying rubber dam. As I said, all procedures recommended should be left to the clinician's best judgment. If I apply rubber dam in this case, it will be decorational. If you want decoration, I can apply it. Yeah, please, sir, proceed.
We have removed caries before removing the gutta percha from the canal. So there is least possibility of any carious substance entering the canal. Secondly, after removing the GP and after preparing the post space, the only source of contamination can be the blood or the saliva entering the canal space, which will be taken care of during irrigation as well as disinfecting the canal space before fixing or cementing the post. So the bacterial control can be achieved reasonably well without a rubber dam also. But yes, ideally speaking, if you go by the books, rubber dam would have been the ideal choice. But for practical purposes and seeing the comfort and convenience of the patient, we have selected not to use a rubber dam in this particular situation. Yeah. Also because we are also educating and speaking along with the procedure, the duration of the overall procedure is more than usual. So because of that also, we have decided not to use the rubber dam for this particular case.
I would like to add one thing to this. Normally, when you see the images, most of the people are quite carried away with the photographs and pictures of the cases which they see from international authors. In their situations, in their working conditions, the payment made for all the procedure is third-party payment. Third-party payment, they refer the cases to another specialist of dentistry. They will find out whatever shortcomings are there in the treatment. If rubber dams are not applied, they will not sanction the payment because it's a rule. So whether it is required or not, for the purpose of clearance of the third party or to follow the standard of care, they will apply rubber dam, though it is for decorational purpose. Because in such cases, what they will do, the rubber dam sheet will end 3 to 4 mm short of the gingival margin. Is it playing any role in such cases? That means it is for the purpose of the photo, and we usually work for the patient and not for the photo.
Is rubber dam really needed during crown preparations? So anyways, we are using a aerotel bar and we are using preparations. So when we are working subgingivally, anyways, you don't need a rubber dam because it might even interfere in your work. So it's better to do it without a rubber dam. I'll answer one question. States that is it possible to change inclination of the crown doing cast post in case of single tooth crossbite? Now, if you're seeing a single tooth crossbite, that means the maxillary tooth is lingually positioned as compared to the adjacent teeth, and it is locked by the opposing antagonist tooth. So, in such situations, you have to see what is the degree of reverse overbite which is present, how much is the depth of that, and whether you will be able to reduce that much of tooth structure at the same time without compromising the actual height of that particular tooth. That is one point. Second thing is we need to change the inclination of that particular tooth from lingual to labial to relieve it from crossbite. But that is possible only within limits. As for this procedure, you need to remove more of lingual tooth structure and reduce less of labial tooth structure. But this will be limited in possibility because you cannot aggressively reduce the sound tooth structure and then cement your entire crown on an artificial post and post. So it's better to opt for some other means like orthodontic tooth correction or correction of the overall incisional guidance of that particular patient, rather than opting for inclination change just by using a post and post.
I would like to add one thing to this, that post and core, by using tailor-made techniques, is the only modality of treatment that provides you easy change in inclination. I'll show you in this case only how are we going to change it, because inclination needs to be changed here. Central incisor is labially inclined. I'm going to change the inclination of the central incisor by almost 15% here. 15 degree, I'm so sorry. Small piece of cotton to block. ಆಕಾರ ಆಕಾರ ತಗೊಂಡು ಕೂಡ
Okay, question, when to use parallel and when to use tapered post? It all depends upon the configuration of the canal and the tape surface of the root. If the root itself is bulky and parallel in the surface, then you can use any kind of post. The root is very narrow, then tapered
ಆಕಾರ
then the parallel preparation is preferred. But if the canal itself is tapered, like in an anterior tooth, canal is generally tapered from coronal to apical direction. So in that case, if you're trying to prepare a very parallel preparation, you might endanger thinning out dentine in the apical half of the tooth. So in that case, you have a coronally parallel and apically tapered preparation. In any event, parallel is superior to tapered because tapered will prepare wedging forces. So if patient is biting on the tooth, wedging forces can have a higher effect on splitting the tooth as compared to parallel. So parallel will distribute occlusal load more evenly against the entire length of the tooth. But practically speaking, parallel may not be possible in anterior area in most of the teeth where you have a tapered canal. So in that case, we select dual tapered or parallel and tapered combination, apically tapered and coronally parallel preparation for the post.
Yeah. Thank you, sir, for your inputs. And I will elaborate on the scientific evidence available and the studies about it. The initial design of the post universally was a tapered design. And if you see the natural taper of the canal, a tapered design will cause uniform contact with the canal walls throughout. Uniform contact with the canals throughout will have a wedging effect on the root after the forces are acting. So this wedging effect will promote more of a vertical root fracture. However, parallel posts will distribute the force more laterally as compared to a more wedging direction. Hence, theoretically speaking, parallel sided posts are more preferable as compared to the tapered post, because tapered posts have force distribution in such a pattern that they can promote the root fractures at times. However, the problem of the parallel sided post is in the apical 1/3, where the root is the thinnest, their diameter could be bigger. To solve this problem, posts having parallel design and tapered tip were designed. However, scientific studies indicate there is no difference in the performance of parallel sided posts and tapered posts with, a parallel sided post with parallel post with tapered design. So if you have to select, you can select either a parallel post or a post with tapered tip and the post having parallel walls.
I think the best decision would be based on the shape of the canal. If canal is tapered, choose a tapered post. If canal is parallel or possible to be prepared parallel, choose a parallel post.
Wait,
The
ma'am,
tapered
आने के बाद
post does have a little bit higher chance of displacement
वंदे भारत
out of the canal than a parallel
आराम से आएंगे.
because of some translation into horizontal forces.
Sir, we have to decide the length. Just guide me if I'm right. See it clinically, not in the microscope. So see the length. Down, 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 down. नीचे देखो ज़्यादा. Length is wise, okay. Length wise we are okay. No, sir, I am going to, no, sir, we will have to keep it the way. We don't modify the metal much. Kava. करायचं दादा करायचं थोडं खाली बघायचं बस exposing the margins. This stage will be bypassed if you have a good ferrule. Not having a ferrule, I'm ensuring that the crown rests directly on the root surface and not on my core. Dr. Sumit, sir, please elaborate this. Try and explain. Most of them may not get
What
it.
Dr. Abrar is doing here is he's removing excess wax from the intracircular area, so that the tooth structure is exposed for bonding or cementing with the future crown, which is going to come in place. So the ferrule will be given by the core plus the crown. So the crown also will give some ferrule, and the margin of the crown will rest apical to the junction of core and the tooth. Both the margins cannot be at the same place. We try to keep the margin of the crown 0.5 to 1 millimeter apical to the margin of the core. Both cannot rest at the same level or the same position. Both will contribute to the ferrule. Regarding the height of the core, we have to see the space available for our prosthetic crown. So in case of a PFM, as we know that we need minimum 1.5 millimeters at the incisor level. So we need to leave 1.5 millimeters from the antagonist tooth and then decide the height of the core. And we also need to see the diameter and the height of the core for sufficient retention and resistance. That is equally important because we need to see diameter and height both, depending on the tooth. Now, anteriors, in usual cases, height is not much of an issue. But yes, in posterior, there is a limitation to height because as we go posterior, the height of the teeth decrease. So in anterior, you need to just see that you get sufficient height for the retention. And in case of normal bites, it is not an issue. But yes, if there is a deep bite, you need to have a very cutthroat situation. You will have a very compromised height of the core also. In that case, you need to think of some bonded crown to increase or enhance the retention.
Yeah, inlay wax.
The stages, the material which is being used for this kind of procedure has been inlay wax. And the reason being that during cooling of this wax, there is minimal shrinkage of the wax. So it adapts accurately without shrinking. Secondly, when we are going to cast this, it will leave no residue and complete burnout will be possible without any residue. And that will lead to more accurate castings. So that is why we are using inlay wax. Later on, we will also demonstrate you how the pattern resin material is used for this procedure. both have their pros and cons. But since ages, inlay wax has been in use, and nowadays we have pattern resin also. Of course, yes, later on we'll even discuss about the newer techniques like CAD/CAM and computerized procedures for designing post and core.
You can now see Abrar sir has clearly exposed the margins of the tooth so that you can actually appreciate where the original crown that is going to be prepared on the tooth will rest on the natural tooth substance and not on the core material. He's carefully removing inlay wax from the surface of the tooth near the margins, leaving the margins exposed. This is the exact way of preparing the pattern for the core.
हाँ करा थोड़ा सा उघडा तोंड तोंड खाली बघा थोडंसं खाली बघा हाँ बस लॅम्प थोडंसं फ्लेम वाढू शकते का रे हीटच करत नाहीये हा करा दादा थोडं खाली बघावं दादा हा असंच ठेवा हा तोंड यस
Here, when we are shaping the core, sir is imagining the future shape of the crown which is going to come in place and the change of inclination which sir was talking about. So he has already planned for the emergence profile and the change in angulation of the prosthetic crown as well as the morphology of the crown which is going to be planned. You have to imagine and accordingly shape the core. Minor adjustments can also be done in the core after the casting is done, but that has to be restricted to minimal.
Because drilling the metal is much more cumbersome as compared to managing the so eliminating anything from the wax is much easier. I'm going to do certain modifications extraorally now to reduce the material in the cingulum area to create a concavity in the cingulum. See, this is now my post, so this cingulum area has to Centered. See, how am I using my instrument here? Now I'll use heated instrument. Started to look like a tooth preparation now. Finishing the wax. Appears good to me now. Your comment, sir? Sir, is it satisfactory? Shall I declare it final, sir? Shall I declare it final, or you want me to do certain modification? Yes, there is a little modification needed on the palatal marginal area. I will do that. Put off the AC, please. This is the flame is dangling because of the AC. हाँ करा दादा थोड़ा सा उगड़ा.
I think here the microscope plays a major role because we are able to appreciate the adaptation of the wax over the margin, which might be not possible without a microscope.
This turned out to be quite a cumbersome case because of the destruction we encountered, both of the teeth adjacent. Okay, otherwise it takes around 5 to 8 minutes to complete a pattern. And naturally, we're doing a peaceful job. हाँ करो. Oh. So what? Now come to the final finishing of the pattern. करा दादा तुम కూడా all of you can appreciate. I'll take the microscope on a highest magnification to show you. Light input वाढवा रे जरा. I'm showing you the post at 40x magnification, different angulations, okay? So that's how we have formed it. I'll show you the parallel margin at 40x magnification. And I will make the adjacent pattern relatively a bigger speed because we have a lot to catch up. Aha, very good. The chair systems are already down. Put off the supply of the chair. Chair is acting up today. Put off the supply of the chair. Again, put it on, please. Let me focus and then. Yep, this is the parietal margin. This is the excess that I'm removing. Last bit of it. See, I've now focused. Dr. Anand Bidve sir is guiding us here. Yes. You can see it from the parietal aspect, the preparation. This is too much labially inclined that we will take care in the later part of it. Keeping this aside. Sir, may I switch to the next pattern so that we don't lose on time? What time is it now? Huh? Manoj sir, how much time we have? Are we behind the schedule or ahead of the schedule? What are we at? What are we looking at? Or shall we directly switch on to? The patient's work also has to happen fast, no? Sir, you'll take the pattern in the lateral. Center and center. You proceed. Give him a break. Give him a break. Give the patient a break. To be more mutilated than it appeared on the X-rays, and it appeared on the procedures before microscope was used to visualize it. May I have any questions, if at all there? What is the question? Oh my God, these many questions have come. When used, thanks for sharing the experience to use of a rubber dam in this case. I really appreciate your work, sir. Thank you. I'm very thankful for the positive comments, and I welcome negative comments as well. It helps me learn. Are the core margins defined? Is there a core ferrule? Yeah, I think our subject expert today has guided so well about the post ferrule as well as the tooth ferrule. But I would like to mention one thing, that whatever decisions we make, we don't justify research in a patient. All our decisions are based on whatever is the best to serve a patient. The tooth which I worked on defies most of the scientific principles. I, being an academician for almost more than, say, around 19 years now, what am I saying here is, this I feel, my gut feeling says, there is a senior prosthodontist with us, and veteran Dr. P.D. Joshi sir is with us. We have taken guidance from our perio department, our prostho department as well, that this post will definitely serve the patient for a few years. So if suppose, what is the alternative? Removing this tooth, and obtaining exactly the same anchorage with a screw. So would you not prefer, unlock the mobile, would you not prefer the root to an implant? Simple as that. And if the root fails, implant option is always open. You're not shutting off any door here. Is it possible to change inclination of a crown doing cast post in case of a single tooth crossbite? This is a good question. Yeah, I think sir has taken this question, but I will elaborate why I have taken up this procedure. Though most of you feel that is an obsolete procedure, nobody does it nowadays. There are two distinct reasons why this procedure is not being performed. It's not because it's metal being used in the tooth. Primarily, it requires a lot of precision on the part of the operator. I do not say that we don't have precision. Lack of training, lack of expertise because of lack of practice. One. Secondly, dependence on the lab. The lab has to do a very good job without any casting defects. All of us have studied casting defects in our first and second year BDS and forgotten it later because we don't bother about them. But every single cast post will remind you of every single porosity that we thought of, any single casting defect we thought of. The only thing that happens is absolute failure. The post will not go inside the canal if the casting is bad, any defects. So one has to be very well versed with the casting defects, eliminate them if they come. Now, when we cast this, and this pattern to Manoj sir, he will send it for casting. If before the completion of today's session, if you can cast it, I will show you the cementation by the end of the day. Any casting defect that comes your way has to be eliminated from the casted pattern. A clear instruction should be given to the lab that cut off the sprue. If at all you want to finish and polish something, do it only with the core portion and send you absolute raw casting of the post surface. Ask the lab not to touch it at all with any rotaries because they want everything glistening and glittering. So they will polish, they will cut, they will do whatnot. The biggest advantage of a cast post is intimacy of contact, the uniform distribution of forces it provides, which is very close to natural distribution of load. So we don't want to lose that. So don't let the lab do a cruelty on the cast post surface. How it is further important wants to join live surgery. I hope we have answered most of the questions here. Now, there is one question that I saw, that how deep we can go. How deep we can go depends on multiple factors. As I said, if you ask me a question about, as an academician, a question about the length of the post, there are 7 schools of thought. There are 7 documented, proven, scientific evidences or opinions about how long a post can be. People have taken various things into account. Some people have taken in vitro studies into account. Some people have taken in vivo studies into account, finite element analysis into account. But however, you can say that as long as possible in the canal without compromising apical seal. Now, how do you not compromise the apical seal? Apical seal is usually better 3 to 5 millimeter of retention of apical obturation. But however, if there is a canine which is going around the root itself in going 17, 18 millimeter, you may not go up to 12 millimeter, not required. In that case, you apply different criteria. And now what are the criteria to be applied? One, simple criteria is minimum, most important criteria is endodontic success. So leave 3 to 5 mm of gutta percha, minimum 5 mm of gutta percha in the apical area. Beyond that, if the crown height is very high, if the crown root ratio 1:1 has to be maintained. Some people have taken into account alveolar crest level. Some people have taken into account clinical crown. Some people have taken into account the recession and the bone level. Some people have taken into account the type of occlusion we have. So preferably in cases of molars, if time permits today, we have a molar case to be demonstrated in the afternoon. So if there is a molar case, do not usually go 7 mm from the canal orifice under any circumstances. Because of availability of adhesive materials, nowadays, we do not need any of posts in most of the molars. Obtain good retention because a single chamber of a molar is worth at least 4 to 5 posts. It's a very wide area available for quality bonding. Remove all the caries, obtain healthy dentine, do good moisture control, obtain good bonding. Most of the molars, you would not require any post. Anteriors have oblique forces and the crown heights are more. So definitely post and core will continue to be used. In current light of bonding, current line of developments of new products and technologies and the quality of bonding being achieved, the requirement of the post in the molars are reduced a lot. Now, Dr. P.D. Joshi sir is starting 1-1 for demonstration using pattern resin for making the pattern. Last question. In every case, we have to give crown as well as the core ferrule. This is the question. Yeah, this is the question. Yeah. In every case, yes. In every case, you have to have a ferrule. See, simply don't get into complex theory. Those people who are not in touch with theory, I would like to say one simple thing. Have 2 millimeter of tooth structure above the level of the gums. That simply explain everything. So if you don't have that, what? Should you extract the root? May not extract the root. If you feel that still it can serve the way we have done it for 2-1. So okay, 2-1 does not have a ferrule, but still we have tried to do something which will retain it for a long time. I hope I answered that. Thank you. Over to sir now. Yeah, sir is adding something.
Abrar just mentioned in this particular case, we were not able to achieve a complete 360-degree ferrule, but there is a concept of a partial ferrule in which you prepare and create a ferrule only on maybe more than 180 degrees of the diameter of the tooth. So that is also sufficient in some cases. Yes, it is not ideal, but yes, it can be done because sometimes there is caries extending below the gums. Sometimes there is demineralized tooth structure or fractured tooth. So in those cases, you won't be able to get a complete 360 degrees ferrule. So partial ferrule is also allowed in such cases, but yes, it is a compromise situation and you need to consider the occlusal load which that tooth is going to be subjected to. So if the occlusal loading is anticipated to be on the lesser side, you can get away with the partial ferrule also. Now over to PD Joshi sir, he's started with his clinical work.
That's the tooth that I'm going to demonstrate, the one. You can see it's more or less prepared. You might have a little bit of undercut in some areas, like here. This undercut needs to be removed because the pattern can get locked over there. So I'll just smoothen that out. Now, this one is a method where you don't have an in-house casting facility. So you need to send it to lab, and in this heat, while transferring the inlay wax pattern to the lab, the pattern can distort or can get damaged because it's a delicate structure. So if you're doing it in-house, it's fine. But if you are in a practice like mine, from where the pattern goes to other end of the town for casting in this heat, you need to have something little more strong and durable. So we have these kind of posts which are castable, made of pattern resin itself, and you just have to apply pattern resin around it and remodify them to the inner anatomy of the canal, and then over which you will build up your core in the same material. So it becomes a one-piece material. So this is one of them which will go into the canal. I can prepare the canal a little more if I want. And but I think it should be sufficient in this case, so I'm just leaving it at that. Now the post is fairly loose and jutting out of the canal, so I can actually cut the tail of the post so that it fits a little more into the. So can I have the scissors? So I'm going to describe to you a very short and sweet technique. I hope it gets over also very quickly. So here is the post. I can still cut a little more to make sure that I don't need that length. You can cut it with burr or you can cut it with scissors. And I can cut the head also off, but I'm going to select a core form around it so that I can actually load the core form in one go and get the core directly. So this is the core form which I'm using. I'll just show you on the screen. You can see there are different sizes available and you can choose the one that will fit on the tooth approximately. I have one smaller diameter and a little bigger diameter. You can just clean up some blood from here so that doesn't interfere. Now you can see I can just hold it against the tooth to see if it is sufficient for me to cover the surface of the tooth, and this is fine enough. I can actually cut the edge as per requirement of the anatomy of the gingival surface of the tooth, the cervical margin of the tooth, but I don't need to do much in this case. So this will be very quick and easy for me. So this I'm going to hold with either a locking tweezer or an artery forceps so that I can just load it and place it and hold it for about a minute or two till it sets. Before that, I will prepare my post. So I'm going to use you can even use inlay wax if you want around the same castable post, or you can use the pattern resin itself. So I'm going to use the pattern resin in my adapted dish. Yeah. So you can see the one which I selected is over here. Now it's on my artery forceps. And you can see you have a molar, you have premolar, and you have anterior, which is there on my artery forceps. So you have variety of sizes available. This particular core form is useful for even direct core buildup. So you place a ready-made or a prefabricated post like a fiber post, and then you place this core material into this core form, and then directly place on the tooth, and you get a nice tapered, already prepared structure, which you just have to modify a little bit more. So let's first prepare the post. So I'm going to use the pattern resin. With some Dapendish. And I'll have some liquid taken into the pipette. You can even take a syringe and take 1 millimeter or so and 1 ml or so into the syringe. So one Dapendish you take liquid, and the other one you take powder. That's our focus curve. Dispense some powder in it. That is pattern resin powder from GC company. You also get Duralay from Colteen. One of the two you can use. Now you use a brush. Here it is. And you can actually fabricate on the core directly, on the post directly by picking up drops and coating it. And then once you have built up sufficient surface, you can load it into the canal. So my post is already built up. I can use tweezer to hold it, or I can use with my hand. And as you can see, I'm going to place it into the canal. And while it is being placed, you can just direct the material into the canal. And you can even reline further. So 1 or 2 times you can do it so that you have a complete proper anatomy of the canal configured. You wait for a minute. While it is hardening, you withdraw and place, so you compensate for polymerization shrinkage, and so that it goes in the same direction. Wait for a minute and then withdraw. You can again reline it so that you are certain of the inner diameter properly picked up. This hardly takes about a minute or two to set. If it doesn't come out, which means that there is undercut somewhere. There has to be some undercut somewhere, then we can remove it before we reline it one more time. So this is a very easy process. Once you learn it, it takes you hardly 5 minutes or 10 minutes to prepare the post and then the core. Now you can see I'm almost about to lift it out. It's still not completely ready for lifting out of the canal. And you can see it's taking up the inner diameter of the inner shape of the canal. It can go back and come out again. It can go back and come out again 2-3 times so that it doesn't get locked in the canal. And then you can reline it one more time, and then you are ready with the core over it. You can see now I'm able to pick it up. So even if you have a small undercut or a rough surface or uneven surface, it will get blocked, and then you will be able to place it, and that would get filled up with the luting cement. So this is almost done, but I'll wait for the material to completely harden. And then I will reline it one more time before I'm certain of the fit. You can actually see rest of this irregularity will be filled up when I place the core material on the surface. So it's almost hard. You can actually test it outside if you have some excess material lying outside to check whether it is hardened or not. and it's already hardened, so I can take it out and I can reline and place it one more time. Let's do reline it. Now it will go in the same direction. It will not go in any other direction. And I don't need too much of material for relining. So it's completely seated in that position. Now I don't have to worry about picking it up. I can actually place my core form over it and allow it to harden at the same time while it is hardening inside the canal. And then whole thing can be picked up in one go. So I'll be mixing in a dappen dish and then filling up my core form. The core form will be filled up and then loaded on top of it like this. Now you have to first make sure that the core form is seating because of the height of it. So once it sets a little, I will cut off the first ball so that my core form will seat fully. That is the height adjustment. You can even see it's taking up the fins of the small extensions that are there on the surface. So it's properly adapted on the surface and it will stay like that. This can be cut off the excess while it is setting. And you can see now my core form should be able to seat on it. If I have any problem, I can still cut the one more ball and everything is going to get fused together. This also creates the space for the cementation because you're going to apply the luting agent on the casting. So this withdrawal and placement a few times will create that very minute micron space which you need for the luting cement. And you can see it'll be firm, it will not move or shake in the position. Let's load the core form now. So here it's a simple how you mix cold cure. That kind of a technique where you can I have syringe? I'll have a small syringe filled up with the monomer, and then I place in the dappen dish. I need a needle also. Yeah, this we can fill up from the bottle itself. So I have a syringe now with the monomer filled up, and I will place the liquid, also simultaneously tap so that it mixes well and settles properly. You don't have to really have too thick a mix. And you can use some instrument to mix it. And then if you feel it's too thick, you can add a little bit of monomer. And then this is ready for loading into the post. उघडं ठेवा, बंद करू नका. Normally, I in my practice, I use an injectable syringe called centric syringe for loading. And once it is loaded, I will place it onto the tooth. And wait for it to set. Now here, this is easily carvable. That means you can actually grind it out, and that requires less control than what Dr. Abrar showed. That requires a little more skill in manipulating wax with a heated instrument. Here, I don't need to really worry about the core. I can just actually do a crown preparation on this core now, as the way I like, and it would be exactly the way I want. I can carve and then send it for casting. So I'll just wait for a minute or two for it to set, and then I will withdraw the whole thing in one go and remove the excess. Again, this surface of the core can be relined to match the surface of the tooth in case you find any deficiency. So this is addable and correctable in the post preparation as well. So you don't really have to worry about accurate seating, because you can correct the intaglio surface of this core against the tooth. So after even final preparation is done, you find one void or air bubble or whatever, you can actually add and correct it. And the whole thing can be cast in one go. Now, added advantage of this is that you don't have any wooden stick or anything holding it. So the whole thing will be invested, whole thing will be evaporated. Yeah. And you can adjust the occlusion. It will not come in the occlusion because you can actually prepare just the way you want it. So there is no excess on this. And most of the time in my practice, this fits as it is. And then I do some final preparation and take the impression. So it saves me a considerable amount of time in my. So this is set. And you can see it's come out with the post, whatever size the post was prepared by Dr. Abrar. And now I can carve off the excess and I can remove this core form later. So I'll first cut off the excess. Which is going around the core form because I don't need that surface. So you can see it can be pulled out from the core form quite easily. And I would like to just show you how it looks like after it comes out. And we can try fitting it now. and then remove the excess. So this is how it was probably fitted, I think. Let's examine and then do the finishing. You can see there's no excess. Yeah, I can do the carving. I can add if I want on the palatal surface, but I don't think I need to add. So let's use a burr and do the finishing. I'll cut the height first off. Again, the same thing, if you want to adjust the direction, space, clearance, everything can be done. And you can see the post that was there in our hand and the material have fused together to like indistinguishable. This I can even carve outside the mouth if I want. At any point in time, even after preparation, if you want any relining, you can do it with just one drop. You can refit it. So this way, it is very user friendly. Sections. So I'll cut it off outside so that patient is not disturbed too much. It will go only in one direction in the canal because of the post. And you can see more or less I have trimmed out the excess. Can I have cutting tip? This is non-cutting tip. No? Okay. So I want to remove a little bit of excess of the fins. So that I can expose the margin. And reduce the height, of course, so it's quite a lot. After all is done, I will reline the intaglio surface once and the post so that it becomes perfectly fitted material. Can I have a flame shaped bar for the yeah, change it. I will prepare the palatal surface now with a flame shaped burr. Close your teeth. बंद कीजिए एक सेकंड. So you can बंद रखिए चबा के. So you can see there is good clearance, and I really don't need to worry about the fit of the crown over it. So I'm just going to shape the palatal surface to its the open anatomy that I want, because I don't want too thick an incisal edge. Done. It's done. Can you have a look? So it's more or less complete. You can see the preparation is complete. All the parameters are fulfilled, and we can just straight away send it for casting. If we feel, that we need a little more adaptation, but I think it is not required because you need some space for the luting cement. So that much of adaptation is not needed. Let me show you it outside the mouth, and you can see it's representing the inner and the outer surface properly. And it will go only in that direction. If I try and rotate it and fit it, it will not go. It will go only in that direction where the entire thing is lined up. बंद करा. So there's good clearance and sufficient height and supporting the incisal edge well, supporting the good clearance for the margins. So the natural tooth is available for cementation or bonding of the crown to the natural tooth substance, covering the core and the post. And there's good ferrule here. We can, if we want, after cementation, we can go subgingival in this case and increase the height of the ferrule. There is a possibility of increasing by another 0.5 millimeter. Well, this is equigingival, so we can go slightly subgingival, and that will make it look even more aesthetic in appearance, and margins will not be disclosed. Okay, I hope you had good time, and if you have any questions on this technique, I can answer. Thank you. You can remove the excess while it is setting, but normally what happens is it tends to flake. So because you cannot control your movement and not tear it off, you should actually cut it off. So it's better to carve it out. And it hardly takes any time for carving because it's just a normal crown preparation technique. Okay, open key. And this is strong, so it will not actually be distorted when it is transferred to the lab. That's the advantage. We put it in a matchbox with some cotton around it and it goes to the lab. And quick and easy, safe. Using spirit lamp for such a long time in front of the patient is a little bit of a hazard. A patient also gets scared sometimes looking at heated instruments in front of him or her. This looks a very standard, safe technique. There may be some pitfalls of it, but most likely I don't think anything goes wrong. And most of the time I haven't had any issue in fitting the post. One thing you must tell the lab when they are investing, whether in Levax or this pattern resin, for casting it. So when they pour investment plaster, they tend to mix it with expansion liquid for their crown and bridge work. And they tend to cast too many crowns, inlays, onlays along with it, and ask them not to use expansion liquid. So that means this has to be separately invested in a small ring rather than, along with many crown and bridges together, because they tend to use a large ring and they put too many crowns, bridges, and in that they cannot put it because they have an expansion liquid, because if this expands, it will not fit in the tooth. So this has to be cast without expansion liquid, only the investment plaster. Yeah. Correct. Infrared. Extra coronal. They want expansion for the cement. An advantage, yeah. Correct. Can you place some temporary cement onto the incisal edge? Thank you. The case is concluded as of now. So we'll be taking a break for lunch. Lunch break would be between it's 1:15 now, so 1:15 to 2 o'clock, 45 minutes lunch break, and then we'll be resuming some more techniques for the afternoon session. We'll join you back again at 2 o'clock for the rest of the day. Thank you so much.
A very good afternoon to all of you. We are back and we apologize for the delay caused for resuming the work back again. In the morning, we have taken two patterns. One cast post pattern was taken with the inlay wax, another was taken in the pattern resin by Dr. P.D. Joshi, sir. Our casting is ready in last 1 hour. And now I will be showing you the casting and the seating of the casting. Get the patient in. Send the patient. शोधायला गेले. Casting. Sound please. हाँ. Can I start go live? ना स्केलर लागेल डेब्रिज आहेत ऍक्टिव्हेट करा. का नाही बांधून ठेवलं? साऊंड किल केलेला. मला 3 ते 4 मिनिटं लागतील हे दाखवायला. त्यानंतर आपण मग हे फॉर्मॅलिटीज करून घेऊ. मॅडमना फ्री करू. ना फक्त दाखवायची फिट. हे बाबा कास्टिंग कोणी घेऊन गेलं बघ. नाही तर जायची निघून. शोधा मग परत. को कास्टिंग घेऊन काय करू. We have received the raw casting here and I'm trying to fit the casting. Yeah, this is precise. Casting appears to be really good. So we will post the picture of this image after we finish this casting. The sprue is yet attached. Show it to you palatarily there. Akara. Fit of the casting is reasonably good at the palatal. Rather perfect. Rarely that you get to see such excellent castings. Yeah, just beautiful. See it. Amazing fit of the casting here. Good. We will cut off the sprue former, finish the coronal area, and do the cementation. Thank you so much. So it's a matter of, in a matter of 2 hours, we could take the pattern. After drawing the pattern, we invested the pattern and obtained the casting. The raw casting has been shown to you. After that, we will cut off the sprue and finish the coronal portion and do the final crown preparation and make impression today itself. Thank you so much. And now we go for the posterior post and core techniques. Before that, we would like to welcome our Honorable Dean Madam for being here, for all the support she has extended and granted permission to conduct all these programs. I can't thank enough to Dr. P.D. Joshi sir for always be a guiding source, our inspiration, our help and support, and man to go for all our needs. Selflessly, he'll be serving the institute for more than almost 2 decades now. We're always and ever thankful to him. And I request Dean Ma'am to felicitate Dr. Sumit Bedia sir, Professor, Department of Prosthodontics, Bharatiya Vidyapeeth Dental College, New Mumbai. Thank you so much, sir. Thank you so much for being here. Brochure. Brochure. Slow झालाय. Slow झालाय. थांब. चल ठीक है. हाँ. Yeah. I request Dean Ma'am to felicitate Dr. Anand Bidwe, sir, eminent endodontist, serving in JJ Hospital currently. Sir, please. He has been appointed as an observer today from Maharashtra State Dental Council for granting of CT points. Thank you so much for coming, sir. 6 grade points. I request ma'am to honor Dr. P.D. Joshi, sir. Sir. Thank you. तो मिस्टर राहुल का ना बोलो, मिस्टर राहुल. हाँ, because they manage all audio, visual and registration process. I request Dean Madam to felicitate Mr. Rahul for all the support that Alchem has provided us by registering people, maintaining the data, and giving us support for the audio visual. They are our academic partners. Thank you so much, Mr. Rahul. Thank you. Madam, if you permit, we start the next case. Thank you so much. I request ma'am to group of a photo. Come. Sir, come. Sir. हाँ सर. Yeah. Thank you.
Next case is
no, ma'am, we prepare for it. You speak. I request ma'am to address everyone. Call hand mic, please.
This is the third case series or the third program.
PMC ने आज ही नाटक शुरू किया आवाज करने. हाँ, ये कौन है यार? पेशेंट का है मोलर और प्री मोलर. 2 चेयर पे ले.
Program being conducted.
प्रेटो कौन?
I did the effort of.
ये मोलर है. ये प्री मोलर है.
So these are always there.
चाहिए.
And
मराठी समझते हैं? मराठी बोल.
Kishore is there, Dr. Manoj is there, and sir is there today with us. So this is all a joint effort, and I think this series should go on. We would like to come up with a good name for this program, rather. And I'll tell you, this is O3 series. So the continuous process will continue, and wish you best to the Department of Endodontics.
हाँ, बताएं उनको सब. She knows what is. Case series is, we have the next case. In the morning, the case that we did in our series was the 5th case. Now, 6th case, we have a molar. This is the upper and the lower arch. This is the molar tooth that we have. It's the lowest left molar, first molar tooth, which is having gross destruction of the crown. If you can see, post-obturation, clinical photograph after removal of the temporary. So this being grossly broken down tooth, it will require support of a post core. And if you see the pattern of supra-eruption of the opposing tooth, the direction of forces will be very deleterious for any kind of composite bonding, because the cyclic fatigue that the composite is going to face in the long term in such cases is very, very high. And the lesion is mostly subgingival in the mesial as well as the buccal wall completely. We have excised the buccal tissue a little bit, which had actually grown inside the chamber. This is post-obturation radiograph of the same case. Let's see it clinically and start. Nice. चलो आपने कुछ खाया है मैडम? हाँ, chair is again a problem, so put off the supply. Hold on. मेरा फोन बज गया, मेरा फोन पड़ा है कभी, साइलेंट कर देना मेरा फोन, तेरे पास है ना? आया तो फोन रिसीव कर लेना. हाँ पardon सर. हाँ सर, yesterday .41. Yeah. SA41. Please. हिलेंगे नहीं मैडम? डरेंगे नहीं, कुछ नहीं होगा आपको। सक्शन पाइप इज ब्लॉकिंग माई विजन। प्रॉब्लम इज हियर। इसमें देख, उसमें मत देख। अच्छा, नहीं मुझे अलग दिखता है, उसमें अलग, फार फोकलिंग नहीं है। कैमरा एंगल एंड माई वीविंग एंगल है डिफरेंट। आप इत्मीनान से बैठिए, आपको कोई तकलीफ नहीं होने दूंगा। कोई तकलीफ हो रही है आपको? हाँ, ये पानी निकाल लेंगे इससे, मशीन से। हाँ, आप आराम से बैठिए, आपको तकलीफ नहीं होने देंगे, जरा सी भी नहीं होने देंगे, ठीक है? क्या करेंगे? नहीं खोलेंगे। आप हिले नहीं। नहीं खोलेंगे। हाँ करेंगे मैडम। हिलेंगे नहीं। You can see the crown preparation. हाँ करो। GMT हाँ। एक ही मिनट रुकिए। आप इत्मीनान से बैठिए, आपको कोई बड़ी तकलीफ नहीं होने वाली है। बहुत बारीक काम कर रहा हूँ, छोटा सा काम कर रहा हूँ। ठीक है, आपको कुछ भी नहीं होगा, आप एकदम इत्मीनान से बैठिए। बहुत बड़ा ऑपरेशन नहीं कर रहा, मैदान का छोटा सा काम बहुत बारीकी से करूंगा। आपको ये नहीं लगे कि कुछ बहुत बड़ा काम चल रहा है। बस कैमरा चालू कर रखा है हम लोगों ने। hemostatic agent, ओ माय गॉड, सुबह में पेटेंट नहीं था वो। सेंटर में आया दांत। वो देना, हीट कैरियर। ये ग्लव बहुत स्लिपरी है रे, हीट कैरियर देना। मैडम, स्पीड कमी करा। घबराना नहीं मैडम, बंद कर माइक्रोमीटर, माइक्रोमीटर बंद कर, चालू कर. Again use ultrasonic scaler. पानी नहीं आ रहा है तो क्या प्रॉब्लम है? अल्ट्रासोनिक स्केलर. चालू करो इसको. We have to work against the wall which is distal, because you can't use any rotary instruments like this in the danger zone. Danger zone is the furcal wall of the middle 1/3 of the root area of the mesial as well as the distal root. Okay, and the canal is dumbbell shape, which I'm turning into into a, you can say, a oblong shape or elliptical types. Now the canal is prepared. हाँ करो. करेंगे, करेंगे मैडम. We see that the GP has been removed. You see a fin of the canal, an extension which is lingual, where there is no GP, but microscope shows that there is a flow of the sealer in that area. And there are distinct undercuts which we need to remove if we want the pattern to be out. Okay. And now we will go after the undercuts. Same burr as the morning session. You have the same burr. EX24, EX22. I'm using a safe-ended burr, EX22, for elimination of the undercuts on the wall, on especially the lingual wall. No undercuts anymore. In the chamber. पानी आहे पाणी. After the preparation, we can see that the post space is prepared. However, we have an undercut on the mesial wall of the chamber. So we now block the undercut there. There are 2 to 3 ways by which you can do it. One is to temporarily block the undercut using a temporary material. Second, you can use composite material without bonding in that area, or else you can do light cure, or you can do the glass ionomer restoration directly. In current scenario, I would select to do a composite without bonding, which I will subsequently remove, allow the luting to spread in that area, so that I can use maximum space area for extension of the metal. Give me composite and light cure machine, please. You will make the posterior pattern, or I'll make it. Sir, you want to make it? Let's see how it goes, because mesial wall is slightly bleeding. So wax mate will be tougher. Hello? Wax. Oh, है क्या instrument है? We have a 3M material. I'm not used to Abrar. It's sticking. करो रिट्रैक्टर है क्या इधर है? क्या हो गया? वो देना. हाँ. ओपन. बंद करो. बंद करो. मुंह खोलो, और मुंह खोलो पूरा. थोड़ा आराम से रहो यार. थोड़ा सा रिलैक्स करिए. बंद करिए अभी थोड़ा सा. हाँ बस. खोलिए अभी पूरा. बस. Those instruments. हाँ करेंगे थोड़ा सा. ना मुझे ना दूसरा मटेरियल कंपोजिट दूसरे कंपनी का, इसको आदत है मुझे. देखो ग्लास है नंबर दे थोड़ा सा. मिक्स लाइट अमाउंट ऑफ रिया में अपने पास. यूजिंग है ना यहाँ. कंटिन्यूस लूजिंग है. Lead care. Where are the? I have made it in the morning. Give me another toothpick, please. नहीं, whitish in color. White. Separating media. Lubrication. हाँ करो. हाँ करो, बड़ा सा मुंह खोलो मैडम. खुला रखिएगा, बंद नहीं करना मुंह. लुब्रिकेंट. बना के रखनी। खुला रखिए। इसको लूज छोड़ेंगे ना तो ये तकलीफ नहीं देगा। इसको हमेशा आपको इसका एहसास करेंगे ना। हाँ करो, पूरा मुंह खोलो बड़ा, छोड़ो लूज अभी। हाँ हाँ बस, एकदम गाल को लूज छोड़ेंगे तो ये तकलीफ नहीं देगा आपको। फिक्र नहीं करिए। ब्लेड कुठे गेली रे? बीपी, लैंप, वैक्स। एसी बंद करा। स्पिरिट लॅम्प खूपच छोटा आहे. दुसरा स्पिरिट लॅम्प आहे का तो जरासा फ्लेम देईल मोठा? कुछ नहीं होगा, आराम से बैठिए। We have added a lot of material drop by drop. Now we will take it off. First of all, that will prove whether do we have an undercut or we don't. If the undercut is found, this will not going to come out at all. It will break. I'm removing the buckle excess before that. बघू दे. अरे मला बघू दे, बाजूला हो.
Good afternoon, everyone. There were a few questions which we had to answer, so we'll take up this time to answer those questions while Abrar sir is patiently preparing the pattern. Posterior patterns are always challenging because of the restriction in space to work in that area, moisture control, and the cheek and the tongue interference and the mouth opening limitations. So all these factors come in the play. And once this inlay pattern sets, he'll carve it out and then take it out and send it for casting. So meanwhile, there were a few questions which were related to my technique of using the pattern resin. So I used one red colored pattern resin ready-made post, over which I applied pattern resin to customize it for the post space. And that was from Angelus. So it's still available in the market. And there are many castable posts available in the market. So you can choose from any of them. And the pattern resin was from GC. And the core form that I used was from Pulp Blend. So these are the three products that we used. Even in this case, it could have been done. We could have placed that post, customized it first. And once we were sure that it's coming out of the canal properly, we could have just laid it up with the pattern resin. Both techniques work very well, and is the operator's choice of working on that case. Secondly, I had also mentioned about casting at that time. All these things go for casting, and Dr. Abrar sir already showed you the morning casting, how well it was fitting. So it all depends upon how the pattern is made, and then the casting technique is used. The most important thing would be not to allow any expansion to take place during the casting. Normally in an extra coronal crowns or bridges, we do some kind of an expansion of the metal, but here we don't do. In fact, the shrinkage would be useful in this case. But normally we don't even ask for shrinkage. We just ask for not to use any expansion liquid in the investment plaster when you pour it around the pattern in the ring. Rest is all the same. And the difference between the two technique mainly lies in the sprue the wooden sprue that is attached to this inlay, and I mean the wax and the uh, either you have a sprue or you don't have a sprue. It's easier to carve in the mouth. So choice again is yours of how to what kind of material to use depending upon the convenience at that point in time. So you can see now the pattern prepared of inlay wax is out. And the moment you know that the pattern has come out clean, that means it has been formed very well. And you also know that there's no undercut anywhere else. Otherwise, the pattern will not come out easily. And you can also then be sure that the casting also will fit. And in both the techniques, you can actually reline the post and also the intaglio surface of the core against the tooth to remove any surface irregularity and allow a better fit. There were many questions related to endodontic procedures, like hand filing versus rotary filing, episectomies and all that. They are not related to today's topic. So please ask them at the current relevant time when we are performing those procedures. And you will see them in future in similar live sessions.
And now we are working on the discuss of madam removing any excess over there. Hold this. We have worked on the mesial wall now. करो. Continuously, sir, please.
Yeah, so Dr. Abrar is still continuing with the pattern fabrication. So we'll discuss a small topic, that is selection of the core material, depending on whether the tooth in question is the anterior or the posterior. Now, in anterior case, as we have seen in the morning session, the core was made in metal. So now, since the core is in metal, we have some restrictions in terms of selection of the crown material. Since it is a metal, it will be very difficult to use a translucent crown like a lithium disilicate or a Emax, which is the brand name which is available. So lithium disilicate crowns will be practically impossible to use. Can be used, but there are a lot of effort required to use that. So preferred choice of crown material in these cases will be either a PFM crown, that is porcelain fused to metal, or a monolithic zirconia crown, which is opaque in nature. So to mask the beauty of metal lying underneath. But in posterior cases, you can easily get away by using a metal core, because most of the times you will be doing a PFM crown or a full metal crown or a monolithic zirconia crown, which are opaque in nature, and the metal you will not be seen. And another topic is related to luting cements used for post cementation. There are a wide range of cements which are available. But the most important factor we should be focusing on is the film thickness and the bonding mechanism of that particular cement, and the compressive and the mechanical strength. But film thickness plays a major role in posts, because we have a defined film thickness, the cement space which we have kept during fabrication. There will be some space which is available for the cement space. So in that, we have to see that the cement is completely filling that space. There is no void. At the same time, during post installation, there should not be undue hydraulic pressure. So the insertion or fixing of the post should not be a fast procedure. It should be gradually inserted after the cement is introduced in the canal. It should be gradually inserted so that the excess cement gets time to come out of the canal, and there is no undue hydrostatic pressure created in the hydraulic pressure created in the canal, which can even lead to post fractures or the canal fractures or the root fractures. So there have been documented cases in which the roots have fractured because of excessively high hydraulic pressure created during post cementation. So in these cases, if the film thickness of the cement is very less, it helps the cement or the excess cement to come out easily. So don't use a viscous cement. Okay, then comes the bonding, whether you are cementing or bonding the post. Of course, if it is a metal, it will be mostly cemented. So there are many cements like zinc phosphate, zinc polycarboxylate, glass ionomer cement, which can be used for cementing it. You may even use a resin-based cement, even without bonding, but at least it will be having a good strength, mechanical strength to resist any load. So you can still use a resin cement without bonding. Or if you are keen on bonding, then you might use a metal primer on the post and try to bond the metal post also with the radicular dentine. And radicular dentine in general uh, is not a good substrate for bonding as compared to coronal dentine. And especially it is said that after root canal procedures, there is a recent study which I have seen that during root canal irrigation, the various chemicals which are used, like saline, hypochlorite, chlorhexidine, EDTA, okay, those alter the texture of dentine at superficial level, which makes it difficult to bond even your core as well as the post. So radicular dentine by itself is difficult to bond, and after your root canal irrigation and chemical contact with various chemicals, it becomes even more difficult to bond. There is some alteration in the chemistry of the radicular dentine which happens after irrigation protocols. So that also needs to be seen, because there is a recent study on core material which I came across, in which they were just comparing the core built-up, which we routinely do. We call it the POR after root canal. So the bonding of the POR material to coronal dentine after irrigation with 2 or 3 chemicals like hexidine, hypochlorite, DT, and all, that is altered as compared to nave dentine. Okay, so this is one point which came across, so I wanted to share. Thank you.
See, and occlusal height is more than required. In the end, I will adjust the occlusal wall height. Height gives me a better sense of taper. So initially, I always keep the height more. You must have seen that you have to be precise in application of the wax. You can use your choice of material. Dr. P.D. Joshi sir and I have demonstrated both the common materials. Pattern resin is much easier to use than the wax, but the wax is cost effective, has a shelf life which is better than the pattern resin. ना करो ना करो खोलो the fit of the cast post, if you can see it, come out reasonably well. Overall, there's one short area that I need to define. Absolutely proper seating now. When I was manipulating the mesial wall, I got a small bubble of the wax there. So this is the reasonable pattern which we have right now. We will clean the surface so that all of you can see. निश्चित नाही. पॅटर्न कुठे ठेवला? This is the pattern. All of you can see it. We need to work on this area a little bit here, smoothing this so that we don't get complications there in the casting ultimately. करो मैडम, करो. टर्न करो इधर. करो मैम. हाँ, you see the marking, the margin has become well. This is how the margin has become now. So we draw this pattern out of the mouth. And temporize it. Occlusally, this has to be adjusted. Almost 1.5 millimeter reduction will be required. That we will do on a lab micromotor later, as time is not permitting us now. Chalo. Give me the temporary though. We are through the pattern. थोड़ा रखिए, थोड़ा सा बस. हाँ करो आप. कुछ कर लीजिए. बाहर जो पेशेंट रुकाए थे, कोई झगड़ा नहीं कर रहा है ना? भेज दो. मैनेज ऑल द पेशेंट्स वेल. We have seen that a lower left 6, we have prepared the tooth, prepared the caspo space, and then we fabricated a direct wax pattern inside the patient's mouth in the 3/6. Now this will be casted and placed back. As I had initially told, that length of the post does not remain that crucial beyond the point of length 7-8 millimeters in the molars, because again, even though it's a casted material, the chamber offers excellent retention area. So counter rotation is important and depends on the opposing tooth and the occlusal height of the core required. If you have sufficient ferrule, in this case, we have ferrule almost in 2.5 walls. So we did not require to go much inside the canal and to jeopardize the strength of the root. So I think this explains the case. So I invite both of them for their expertise and comments on what happens. And if there are any questions, Dr. PD sir and Dr. Sumit sir can take up. Thank you so much for attending, sir.
For an excellent demonstration of the pattern on the posterior tooth. It's such a difficult thing and so less practice nowadays, and everyone has to learn these techniques, and from time to time can be used. Thank you so much for attending, and we wish you all the best and wait for our next program to come up. Thank you.
Thank you all the registered participants for attending this program. I would just like to add a point on recent advances like use of scanners for post and core. So nowadays you can use scanners for making impressions of the prepared tooth and the post space which you have prepared. And then the entire designing part is done using the CAD, and they can be milled in either zirconia or they can be in PEEK and maybe some new materials which might come sooner. So zirconia posts as well as PEEK posts, they can be used using a CAD-CAM technology. Although the use of scanners for post-space recording is still being researched, there is no definite consensus regarding it because different scanners show different results. Because it being a long area, the light is not able to reach till the depth of the post space, and they may not be able to record the entire post space correctly, depending on the brand of scanners, because the resolution and the depth and the diameter and the curvature, all these factors will determine the accurate recording of the post space using a scanner. But once it is recorded, then milling and CAD part is not a problem. The only challenge remains is recording the post space accurately, because light doesn't reach the end of the post space. So these challenges are still there. I think the companies will soon look into these issues and solve them by upgrading their technology. We will soon have scanners which can record the post space accurately. Okay. That's it. Thank you for attending the program, and we look forward for your participation in the next event also. Thank you very much.